In 1999, the Artemis 1 was created. It was a very interesting machine because it reversed the water bath. Now, all of you who know, we used to do ultrasound with the patient lying down, have a water bath on his head, over his eye, and we used to hold a UBM probe over his eye, and we'll do all the scans. And that was very imprecise and very, very crude. So what they did for the Artemis 1 is they turned everything upside down. They reversed the water bath setup, and they designed a headrest so the patients would actually lie down and immerse their eye in a water bath. So that was revolutionary. Also, the patient could see the target and the eye could keep still, and the probe would move from left to right, up and down in different angles to scan different axes of the eye. Now, I got involved with the Artemis 2 in 2006 because I started looking at implanting ICLs. And the most important thing about implanting ICL is the sizing. Now, I really enjoyed the Artemis 2, even though it was difficult to use, but it gave superb results. The only thing was that the technology was good, but maintaining the machine and getting it serviced and getting it was very difficult all the way from Singapore. But I managed to do it. And unfortunately, about a year and a half ago, this machine started to give trouble. But I was very lucky because the Artemis 3 or the Insight 100 was created. Now, this machine was a much better machine than Artemis 2, much more user-friendly. And unfortunately, you still have to wear an apron because occasionally the water would leak and you would still get a little bit wet if you didn't wear an apron. So you still had to lean forward and still had a water bath, but it was much simpler to use, as you will see later. Now, the Insight 100 machine is an excellent machine. Now, I'm just a normal, plain old ophthalmologist. I'm not smart, so I surround myself with smart people. And in the center, you see, of course, Professor Dan Reinstein, and he's one of the smartest people I know. On the left, you know David Chang, and he's a cataract surgeon from San Francisco area. So I surround myself with very smart people, and I learn from them. Now, the Insight 100 machine is an excellent machine, but with Dan's applications, as you will see later, it becomes a superb machine. Now, the Artemis Insight display is very, very simple, and later on I will show you a video of how it's used and how fast you can get an on-axis fixation image of the anterior segment of the eye. Now, what about the accuracy? As I told you, the Artemis was created with superb accuracy. The epithelial thickness measurements repeatability was 0.7 microns. The corneal thickness repeatability was 2.3 microns. And the equator of the lens diameter was 130 microns amount of variability. Now, if you compare with the rest of the UBM machines out there, you can see that the Artemis 1 was pretty good, but the Insight 100 was the best. Everything else is inferior to that for the measurement of angle to angle and sulcus to sulcus. This was a study done by Carlo Lovisolo. Now, I'm not in a research center, neither am I in a university or public hospital. As a private practice ophthalmologist, I use the machine mostly for the following: ICL sizing, diagnosis of form frust keratoconus and ectasia, to view behind an opaque cornea, angle closure glaucoma when the cornea is very cloudy, and lens subluxation or loose zonules. Now, ICL surgery, sulcus to sulcus measurements. When I started looking at phakic IOLs, the most important thing I gathered from all my research was the effect of sizing, especially for lenses in the posterior chamber. That means posterior chamber phakic IOLs. Now, if you look at ICL complications, and this was from the FDA study, you could see that there was endophthalmitis that occurs in every intraocular procedure. Cataracts, that usually occurs if your ICL is undersized and is lying on the lens. Glaucoma, oversized ICL, angle closure glaucoma. ICL subluxation, again undersized ICLs, and endothelial cell loss, not really in ICL implantation if you have a good surgeon, and it is definitely not a problem because it's not an anterior chamber phakic IOL. So overall, size is important. Now, if you look at complications, oversizing resulted in 2% of complications. Cataract occurred in 1%. Now, when you see this, your heart sinks. This is my patient. And this occurred because my Artemis 2 broke down and I didn't receive my Insight 100. And this was a period where I had nothing else but to try and use it only with white-to-white measurements. And this patient turned up 1 day after surgery. I felt so bad. I took out the lens, and this patient, I lost this patient because she refused to have another ICL implanted. She said, I don't want to take the risk anymore. I'm nervous now, and I'm not going to put an ICL in my eye. She still sees me because I waived all her charges. Star was kind enough not to charge anything. And the end of the day, I still feel bad when I see her. She's an extremely nice woman, okay? But she understood that ICL measurements and sizing was always going to be difficult. Now, if you have an ultrasound like the Artemis 2 or the Insight 100, it's so easy to measure the sulcus plane and the zonular plane. It's extremely easy, especially with the Insight 100. Now I'm going to show you this. This is from the very beginning, real time, no editing. My optometrists are there. Jessica is measuring the single measurement right across the horizontal axis. It's starting now, and you can see the water bath. If you look at the screen here, you can see the water bath, water going up, and I'm focusing now on the eye. The chamber is filling up with water. The patient is now going to be asked to open her eyes, and now she opens her eyes. I tell them it's like opening your eyes in a swimming pool. So you open your eyes, it doesn't hurt, it's normal saline, it's very comfortable, and now my optometrist will start to scan the eye. This is in the automatic mode. Dan tells me that if I use a manual mode, it will be 10 seconds faster. But it's already fast, so I think in 10 seconds it's not going to matter that much. The probe, you can see, is moving from left to right, and you will see an image of the anterior chamber appear there. You can see it just appear there. And it's done, I think, less than a minute and a half. Now, the water now will slowly drain. You tell the patient, don't remove the head or not the water will spill. So you can see the water draining. And she's finished one horizontal scan, no editing, all real time. Now, for those of us who know Dan, he is a really smart guy, and he's created this calculator with all the measurements from the Artemis or the ICL or the Insight 100. You can get this image and you can see all these numbers. There is a software update to this machine where the figures are placed in it for you. Now, all of us want to see this. We do a scan after ICL surgery, and you can see the foot plates. You can see every aspect of the ICL. In this case, she is 477 micron vault. You can see the foot plates, and you can even see the angles of the anterior chamber. Now, correlation of anterior segment dimensions and ICL applications. Now, Dan is going to go through this in much greater detail. Suffice to say that there is a very poor correlation between white to white and STS, which is sulcus to sulcus. In other words, when they tell you white to white gives you this dimension of ICL you're supposed to use, it's not going to be accurate. Now, this is a study done by Lovisolo again, and this study showed that in 54% of patients, using the white to white method, you are not using the ideal lens size. In other words, 54% of your patients would have got a lens size that is either too big or too small, but they are still okay, but not the ideal lens. So in 50%, less than 50% of the cases, you have put in an ideal ICL size. But in the remaining, you're now stuck with an ICL that's slightly too big and slightly too small, or very much too big or very much too small. Now, if you have less than 90 microns depth, you basically end up developing cataracts. So you have a theoretical risk in white-to-white measurement sizing of 36% of getting a cataract. Now, I did a small study myself for the Artemis 2 and the Quantel STS, and we found a relatively poor correlation for smaller diameter eyes. You can see that, or smaller sulcus to sulcus eyes, you can see that the Quantel underreads. And if you look at the bigger eyes, you can see that the Quantel overreads. If there is perfect correlation between the Quantel and the Artemis, both lines should be perfectly parallel. And you can see the upper pair is the Artemis maximum and average diameters. And you can see the Quantel average and maximum diameters. And you can see a rather poor correlation. Epithelial thickness measurements. This is what Dan is going to talk a lot about. So I'm going to skip through this, except to show you that in early keratoconus detection, you are looking for epithelial thinning. And I used their program inside the Insight 100 called the Reinstein Silverman Keratoconus Evaluation. And if you look at the patient here, you can see the topography on the right here, up here. It looks very suspicious. You know, is this asymmetrical astigmatism? Is there a small little cone developing? Well, I used his evaluation application, and you can see that there is a risk score that is in red that tells you that this patient most likely has early form thrust keratoconus. The other eye is relatively normal, but again, there is a risk score over here that is beyond the red bar. So in this patient, I did trans PRK with cross-linking, full cross-linking. Now, Dan is going to talk a lot more about avoiding ectasia from false negatives and false positives. You can also measure LASIK flaps with the Insight 100, epithelial flaps, and high myopic LASIK flaps. However, we all know that the corneal OCT is easier to use. But if you had to buy a machine, one single machine, then I would still buy the Insight 100 because it can be used for ICL, it can be used for LASIK, it can be used for a lot more things, glaucoma measurements, so you cover a lot of area. Whereas a corneal OCT can measure corneal OCT, and it has great difficulty measuring. In fact, it's impossible for it to measure sulcus to sulcus measurements. Epithelial maps from corneal OCTs are not as refined and not as accurate. And this is a patient who we measured the global epithelium over the whole eye, corneal stroma, corneal base, and epithelium, and all the rest of the parameters, as you can see. And it's very, very obvious that to see that the epithelium is thicker inferiorly than superiorly. Now, I never noticed this in my OCT maps. Until I saw this, then I went back to my OCT maps, and then you can see it, but it's very, very subtle there. Now, what's the difference between corneal OCT epithelial measurements and very high frequency digital ultrasound measurements? Well, the OCT measurements are found to be thinner, and because the measurement of the OCT includes the tail film, and the true difference is likely to be about 4 to 6 microns. Now, something that is out of the cornea but towards the back of the eye is lens subluxation and loose zonules. Now, in this patient, when I saw this patient, I could see that the lens edge was a little bit exposed, and I was wondering whether there were zonules or not. So, if you do an ultrasound scan with the inside, you can actually see the zonules, both anterior zonules and posterior zonules. In glaucoma, you can do a lot of glaucoma studies. I'm not a glaucoma expert, but I use this sometimes when I need to measure when the cornea is really swollen and cloudy. And you can see angle closure or open angle glaucoma or other features like a zipped up angle, as in neovascular glaucoma. Now, what about opaque and diseased corneas? I'm a trained corneal surgeon, so I see some patients like this. And I developed a very small design, specially designed speculum. It's made by Inami, and it's really tiny, and it can sit right in the seal. So there's no leakage, and it doesn't interfere with the ultrasound scan. The size is really small. It's the size of an SD card, as you can see here. And this is the normal speculum in blue. This is my design of speculum, and that's an SD card. And this is a real patient of mine. This is a patient with very small open aperture because his eye has been ravaged by a squamous cell carcinoma of the cornea and conjunctiva. Now, I started with the last slide, very sorry, because I was running through my slides, and this is basically what I want to say. Very high frequency digital ultrasound scanning will make corneal refractive surgery, phakic IOL, and IOL surgery much safer. Thank you very much.
So I've entitled this talk, Unique Diagnostic Applications Raising the Standard of Refractive Surgery. And my co-authors are Tim Archer, who's my research director at the London Vision Clinic, and Ryan Vita, who's our research optometrist. And I'm going to acknowledge many other people along the way as well. But without teamwork, people talk about my CV, but actually my CV is a great result of a massive team effort. My financial disclosures are that, I have been the lead refractive surgery consultant for Carl Zeiss Meditech for almost 20 years. And yes, I have patents that went through Cornell over to 2 different companies now, ArcScan, and I do have a financial interest in this device, although, I will tell you, I got a check for $175 last year from the Cornell Research Foundation. So I'm way ahead. The real value, I've invested, probably over $1 million personally in keeping my Artemis, my prototypes, and then my Artemis 1 working, awaiting this final moment when I finally receive the Insight 100, and now I can have technicians do all my scans for me. So I just wanted to fill in a little bit about the background. This is the rectilinear scanner that was used for tumors in Jack Coleman's lab. And we just replaced the 10 megahertz transducer, broadband 15 megahertz, with with this 60 megahertz transducer at the time. And this was Bob, one of the retina fellows at the time. And we were scanning, the eye. And I got interested in cornea because of the emerging field of refractive surgery in 1991. This is before any approvals. And no one else was interested or thought it was of interest to scan the cornea. But I thought it was quite fascinating to measure something that had never been measured before. And it turns out that the epithelium had never been measured before, other than one publication 10 years before in 81. Brian Holden was measuring it with a picometer, and he was trying to see whether there were epithelial thickness changes on contact lens wearers overnight. But apart from that, no one had ever measured the epithelium. I checked with the professor of cornea at Cornell if this would be of any interest. He said no. So I knew that I had a wide open field to start my career in ophthalmology, which at the time, by the way, I was just a research fellow. I did my residency. I started my residency 2 years later. And so during my residency, I considered to continue to work at Jack Coleman's lab with Ron Silverman, Mark Rondeau, Tatiana. And we built this prototype to do arc scanning to try and scan the whole cornea, because the original scanner only got 3 millimeters worth of cornea. And here we were able to scan the entire anterior segment. This is, you see the iris here in lens. That's me right there, lying down. If you zoom in, you'll see my name tag here. So that was the first scan ever done on an arc scanner of the whole anterior segment with high frequency ultrasound. And as you saw from Jerry, we gathered up our pennies and managed to start a company called Ultralink, which developed the first reverse water bath system. And the first time that we had a simultaneous infrared image with a Purkinje reflex on the cornea and a simultaneous corneal scan at the same time. So that was the first time that you were able to localize the position of an ultrasound scan visually. And of course, that was critical if you were going to use this for refractive surgery, because refractive surgery is all about being able to do things optically, which means you have to know where you are in the lens. There was an intermediate step, I'm going to call it. Jerry battled away with this Artemis 2. Carlo Visolo had one of these in Milan, which is how we did our early ICL studies. And thankfully, here's the team, by the way. This was just last January, so this year. Ron Silverman, Tatiana, Mark Rondeau, myself, and the other half of the team on my end, Ursula here, my wife, who, obviously always in the background, but she really made it possible for me to work twice as hard. And here you are. So we have this FDA and CE approved device now in Asia. It's approved, and we're Formula One now, because this thing can do basically anything you want. It can scan in 6 degrees of freedom. It could do a spiral scan. It could do a straight, then curved, then straight scan. It can follow any contour of the anterior segment. So it's really designed for anterior segment surgery, because there are too many curvatures in the anterior segment to be able to get one scan shape to work for all scans. And so as you'll see later, we're able to scan the lens because it's able to do different angles at different stages and put images together. So the huge improvement, of course, with immersion ultrasound has been reversing the water bath, and now the coupling, the eye seal, and this ability to get a universal fit, which fits almost all eyes. It's not all eyes, but almost all eyes. I'd say 98% of eyes fit comfortably into this eye seal. And the fact that we can have a very small amount of saline introduced and make the coupling very, very easy and very, very quick, as you saw from Jerry's video. This is really the way that we brought immersion ultrasound to the people. Because to bring it to the masses, you have to get past the enthusiasts, like Jerry. You have to get this thing into the hands of general clinics where technicians are going to be doing the exams. And there can't be the necessity to have a year's ultrasound training with certification in ultrasound before you're able to do one scan. Now, this is our video, which we showed at ACOS. We edited it to make it 20 seconds, but essentially these are the time breakdowns of how it is to do a scan. It takes 2 minutes to do one eye, and it takes 10 seconds to fill to get the coupling and then adjust the head, 15 seconds to fill, 30 seconds to get the ranging, 14 seconds to actually do the scanning, to drain the fluid, 5 seconds to give the patient a tissue and sit back and get ready for the other eye. So our technicians can actually get through, they bring the patient into the room and do these scans, within, I don't know, 10 minutes, the patient's in and out of the room already. And that sounds like a long time, but compared to what it used to be, it's very little time. And as we were discussing just now, if you asked a patient, would you like to spend an extra 10 minutes with your eye in the eye spa with the saline in order to get better sizing of your ICL with a 1% exchange rate? Or would you just want to just wing it and we just see if you get it without the water bath? I don't think there's a patient who's going to say, let's just wing it. Knowledge is power. Now, I want to be clear that OCT has a huge clinical space, and had a lot of real estate in my clinic. I was obviously the first to measure epithelium, so these companies that are starting epithelial mapping obviously always come to me, and yes, and I don't consult for any of these. I mean, I'll say I don't consult for Zeiss Dublin that developed this machine. So I don't consult, the answer is I don't consult for any of these companies, but I have helped all of them mapping. Even though that would be, you would think that would be contrary to my financial interests in ultrasound. I don't have a financial interest in ultrasound. I have a financial interest in giving the patient the best possible safety. And epithelial mapping is critical, I think, to refractive surgery. And so I have, as you can see, 12 OCT devices that can measure epithelium in my clinic. So I'm not against OCT, but I do want to show you the context. The context is that if we think about applications in 4 sectors, obviously epithelial mapping is one of them. We'll go over some of those. There's the intrastromal corneal interface detection. That's another application. Anterior chamber, like behind the endothelium and in front of the iris, that part of the eye, that anterior chamber, that's another sector. And then there's the posterior chamber. And when we analyze the relative overlap between OCT and ultrasound, we find that in terms of applications, about 80% of the time we can get away with just the OCT on the cornea. 20% of the time we still go to the high frequency ultrasound in order to get the real answer for the keratoconus screening, for example, or to find intrastromal interfaces, because ultrasound and light are different. And so an ultrasound interface might be completely transparent to OCT and vice versa. Anterior chamber, of course, almost all of the applications for anterior chamber, except I would say probably in terms of objects that obscure, foreign bodies or blood or something where you might have a difficulty with light other than ultrasound to image things in the anterior chamber. But let's be clear, OCT has zero, well, it's 0.1, because if your iris is completely devoid of melanin, then you can scan with an OCT behind the iris, but let's call it 0%. Okay, if you're not an albino eye, it's a 0% penetrance in the posterior chamber. So whichever arguments you may use to decide which machine you should buy, if it's one or the other, at the end of the day, the answer is both. You can't argue it any other way, because like Jerry said, if he had to choose, he'd choose ultrasound, and I'd agree with that, because ultrasound is the only one that gives you all applications in all circumstances. But let's be clear, we're very busy and our clinics are all about workflow. And so in order to improve workflow, I have OCTs as well. And there are certain instances where the OCT helps me a lot. I can use an OCT almost intraoperatively, which I do in my microscope. I have an Artivo, and it has intraoperative OCT, and that's wonderful. I use it all the time for my ICL surgeries. But we're talking here about raising the standard. And, it's, without, one doesn't want to be prerogative, derogative, or to put down anybody who's not using ultrasound, because the vast majority of the world isn't. But I don't think there's a way of arguing around the fact that if you have very high frequency ultrasound, you are practicing ophthalmology at a higher standard. I mean, it's just, I don't know I don't know how to hide that fact to sort of save on embarrassment. The fact is, if you don't have access to this kind of information, you're going to have unanswered questions, and you're going to make decisions which are not necessarily ideal, and your patients may not be aware that you don't have the technology to answer that question. And so that's okay for you from a commercial standpoint, but it maybe won't help you sleep at night when you have those difficulties that you're unable to solve. So I'm going to move into some details. And, as Jerry mentioned, I have over 40 publications out there in the peer-reviewed literature on just the epithelium of the cornea. And that was before there was any OCT or any ultrasound FDA or CE approved. So this is before it was commercialized. We managed to get, how do you do that? There's no technology in the world that has been put into the market with this much evidence already in the peer-reviewed literature. None in my lifetime that I've seen. Now, how did that happen? Well, it's because everyone ignored epithelium for all these years. And so, if you don't have access to something, you don't have an incentive to have an interest in it. And so it gave me a massive runway, and I'm grateful for the runway from a career standpoint, but it's been a frustrating standpoint. And I think ArcScan, and I can tell you, because I've been through the whole story with them, it has been a very difficult pathway, and they've had some incredibly challenging times to get this machine onto market. And so I think we need to be, all of us, extremely appreciative of particularly Andy, who really came into the company when it was really struggling many years ago. And as an engineer and a business, they're trying to do just everything at once, and getting this thing to the finish line, and not only to the finish line, but where we are now, which is a super easy to use, affordable, technology that can really fit into any practice and can be used by anybody. So let's look at some details, because Jerry mentioned, measuring epithelium with OCT. And, the fact is that the OCT is not just measuring the epithelium. It's measuring the epithelium and the tear film, because it doesn't resolve the tear film from the epithelium. Now, obviously, ultrasound does, because when you immerse the eye, now the first interface is the surface of the epithelium, right? Not even the mucin layer is included. It's the cellular wall that makes the echo, not the mucin layer. So ultrasound is actually measuring the epithelial thickness. OCT is measuring the epithelium with the tear film. And we all know that the tear film can vary tremendously. Here's a perfect example. Look at the epithelial map from my MS-39 from CSO. And this is when the patient presented for a pre-op exam. And this is a month after we instigated warm compresses in meibomian gland dysfunction measures. The tear film became much more stable, much more amenable, let's say, to having surgery. But look how the epithelial map on the same color scale completely changed. So that's because now we have a healthy, even, robust tear film. And so, you might look at this and say there's a donut shape, but actually once you, fix the tear film, suddenly everything looks a lot more normal. Now we looked at these differences when the RT View came out, and I had one of the prototypes way before it was commercialized in 2015. I had a prototype from 2012. And along with the approvals, we published this paper showing the differences in epithelial thicknesses between the RT view and the Insight. And you can see that in the center, there's very little average difference. But once you get to the 3 millimeter zone, you start to get significant differences. And remember that in keratoconus, the cones are, they're in the 2 to 3 to 4 millimeter zone. So it's the 1, 2, 3 micron differences in the epithelial profile. It's those small micronic differences that are going to tell you whether a cornea is keratoconic or not. And so sadly, OCT with its great accuracy, but inferior accuracy, will sometimes miss these very early cones because it doesn't have the resolution to pick up these incredibly small differences. And that's pre-op. If we look at post-op and we compared post-LASIK OCT and ultrasound, same eyes, now you can see rather large differences in measurements between the two. And our paper goes into the physics of why these things are occurring, but just in a nutshell, it's because refractive index changes occur, and therefore the epithelium is much thicker post-op. And now the refractive index that's used by OCT to calculate the thickness makes for this kind of inaccuracy. Whereas in ultrasound, we don't have that issue because the speed of sound doesn't change before and after LASIK in epithelium. So, in terms of accuracy, ultrasound will always have the upper hand because we don't have measures for refractive index to have in every single eye, which is what you need to match the accuracy, as well as being able to resolve the tear film, which might be one day possible by even higher resolution OCT, but still. Okay, so what is the normal epithelium thickness? This is one of those wonderful stories of a paper that was sent to, this is an anatomy paper, right? This is the epithelium of the human cornea. This is 2008. We're into the 21st century, and there hasn't been an anatomy paper published in eyes probably for 100 years since a German ophthalmologist has presented it, since Vogt presented some anatomical Vogt's stria or something. And here we are with an anatomy paper, and I thought, well, I can't send this to just a specialist journal. I've got to send this to ophthalmology, because ophthalmology is like, this is anatomy, this is real, this is big. After a 6 months back and forth with reviewers who were, just not conversant in ultrasound, and despite the senior section editor, well, he basically went with the reviewers, and I was really, I kind of said, okay. I sent this to George Waring when he was editor of the JRS, and I said, look, here are the reviews, and here's the paper. What do you think? He said, I'll accept it right now. I've got the reviews. I don't have to re-review it. I agree with all of your rebuttals, and it was published a month later. This paper has cost ophthalmology a lot of, what are they called? What's it called when your paper is referenced? Citations. What we found was that the epithelium is not one thickness, as is in all of the textbooks. All the textbooks say that the epithelium is a uni-thickness 50 micron layer. And we found that the center was about 50 microns, okay, but we found that there was a 6 micron superior to inferior and about a 1 micron nasal to temporal difference, and that the pattern was mirrored. It was different from right and left eyes, but it was the same in a mirrored fashion. And all of this is explained in my lectures on epithelium, but needless to say, it's all to do with eyelid anatomy and how the eye blinks. We blink 10,000 times a day, and how the chafing and how the forces work on the epithelium. Jerry mentioned our Ortho-K paper, which shows that if you change the eyelid for a hard lens, you move the epithelium around in a different way. So the eyelid has a very important function in determining the epithelial thickness profile. So I want to really concentrate on the keratoconus screening thing, because as you can see, we published these papers quite a few years ago now, but we've been using them since 2004 when I first had the idea. And I'm going to go through the theory of this. It's quite simple. If we think of a schematic here of a normal cornea with the front surface, the stromal surface and the back surface, and the epithelium is what's between the front and back, front surface of the epithelium and front surface of the stroma. In the case of keratoconus, where the front and back surfaces are bulging, what we know is that the epithelium compensates for that bulge. And so you get thinning of the epithelium over the cone, and you get a relative thickening around that zone, which makes it look a bit like a donut shape. And that's what we normally see. But you see, what we, the step forward was to understand why it was that we were still arguing on the podium as to whether the orb scan was better than a relative just an anterior segment, an anterior surface topography for detecting keratoconus. And those of us were saying yes, because the back surface changes first. And you had all these people saying, no, it doesn't, blah, blah, blah. And we were both right. We were both right. The back surface can change first because the epithelium can completely absorb earlier changes of the front surface of the stroma. So we were right in that the front surface topography doesn't change, and the others were right without realizing it, that it was the stromal surface moving forward, but not visible because of the epithelial compensation. So the compensation can be complete, and therefore you can get an absolutely normal anterior surface topography in a keratoconic eye. And when you think that these back surface abnormalities are so small now, because they're being absorbed by the epithelium fully, that they may be lost in the soup. You have an algorithm that tells you, oh, that bulge in the back surface is really keratoconus. Well, if it's really small, the algorithm might say, low probability. But if you look at the epithelium right over the spot where the back surface is elevated, now you've got confirmation that the back and front surfaces are yoked and that there's an extrusion, and therefore the epithelium is the decider in these early cases. And I will show you how just incredibly sensitive the epithelium is at doing this. Now, I was showing this for a few years and I was completely ignored again, as one is. And, Schopenhauer said that the three stages of truth are that the first stage is that you're completely ignored. The second stage is that you're violently opposed. And the third stage is accepted as inherently obvious. And we're at that stage now because it's obvious that the epithelium will hide cones. But here's where OptoView started their program on epithelial mapping, is when I did a study showing that you could have epithelium that was thicker inferiorly, and it was the epithelium that was providing the inferior steepening on the topography, not the stroma. And when I showed that, and I showed that you actually had basically a pseudo keratoconic topography, and we did a 1,500 eye study where we showed that basically our LASIK, we showed that we could exclude keratoconus 84% of the time that the topography was abnormal. 84% of the time we could do LASIK on that patient because we had proof that it wasn't keratoconus. Suddenly, because your LASIK volumes increased by 7%, that means money, and money means you should have a device because it can make you money. And that's when OptoView started their epithelial mapping on OCT. Of course, we were kind of a little behind the curve here commercializing it because this device is a lot more complex than an OCT, and cheaper, by the way. So kind of paradoxically. But we'd gone through the phase of showing that the more severe the keratoconus, the thinner the epithelium over the cone, and the thicker the surrounding donut is. We'd essentially obviously been able to show that there's a difference in keratoconus and normal epithelial profiles, obviously. But the question was exploiting this. And so Ron Silverman and I applied for a NIH grant. We got several $1,000,000 to do this. It was a very difficult project. Fred Litzy is one of the last papers he was on. He was one of the geniuses of ultrasound science in the world. And we developed an algorithm. Now this algorithm is now on board on the inside. And as you can see, the sensitivity, the pickup rate of keratoconus, and once it picks it up, the specificity is higher than any tomography device in the world. And you can include every algorithm on the planet, Bell and Ambrosio, whatever you want. They don't have this sensitivity and specificity. And the reason for that is that if you can measure the epithelium with 1 micron precision, you can detect focal changes in the epithelium that shouldn't be in that region in a case where 1 or 2 microns difference on a front or back surface is going to get lost in the soup of the noise of topography and tomography. So it's very clear why epithelium is more sensitive. And now it's just a question of people, incorporating it into their practices. So and this by, I'm just pointing out here, this is detecting epithelium. Like if you were just screening for refractive surgery, only using epithelial maps, not using any topography, you'd still do better than with topography and tomography, which is, quite amazing if you think about it. So here's some examples. I mean, we have here an example of a topography that looks suspect and a tomography that looks suspect. So it's suspect, the atlas is saying it's 72% normal, but we all know that looks a bit weird. We look at the back surface on the Bell and Ambrosio, and indeed the BAD is quite high. And now we're thinking, well, this probably is keratoconus. But here you go. Here's the high frequency ultrasound map, of course, 10 millimeters of epithelium. OCT never gets 10 millimeters, maximum maybe 8 or 9. But there you see the thinning, the focal thinning over the point where the back surface is elevated. And here's an example where the OCT has been good enough and we didn't have to do an ultrasound. We didn't have to do an ultrasound. But here's an example where you have normal topography but suspect back surface. And here is completely normal anterior surface. I mean, other than the fact that the keratometry is very high. In a patient with 20/16 vision, although a high myope. But this is the back surface of this cornea. And the BAD is huge, right? It's like alarm bell, 15 alarm bells, keratoconus, right? But here's the epithelial map of this cornea. And you can see that there is no focal thinning over where you would expect there to be, a donut, and like none. And here is the RSK, the Reinstein-Silverman keratoconus algorithm. And you can see that we, with the epithelium, can be very confident that this is not keratoconus. The back surface is in a weird shape for a different reason. Who knows? Maybe it's Fuchs, maybe it's something else, but it's not keratoconus, okay? So this is an extreme example. Here's another one, but this is the scary type. This is the part where you say the ectasia without a cause. So you have normal topography, totally normal. You have normal back surface, according to the algorithms, totally normal. But the epithelium shows focal thinning, okay? Focal thinning. And the standard deviation map, in other words, the pattern deviation to the population shows, actually, this is thinner inferiorly than expected. And the RSK is no ticket for corneal refractive surgery. Actually, as Jerry showed earlier, rather, why don't you preserve this patient's vision by a transepithelial cross-linking or a cross-linking, and then put an ICL in using your high frequency ultrasound device to get the highest safety for sizing. So these are the, oh my goodness moments, right? Where you're like, whoa, I just saved myself a huge headache and I just saved a patient years of rehabilitation. So this is an incredibly old slide. but this was what I was using to argue back then in 2006. I was saying, look, you can have totally normal topographies and donut shapes under these topographies, and you can avoid ectasias in these cases using the difference between epithelium of keratoconic and normal corneas. But you can even better, from a commercial standpoint, in terms of justifying the expense of ultrasound and the hassle, you have keratoconic suspects from topography that can be excluded from having keratoconus. And you can go ahead and do the case by exploiting the differences in epithelial profile differences. So again, it can't be emphasized too much how powerful this is. So I'm going to go through a quick little application, which has enabled me to do a hell of a lot less clear lens exchange on hyperopes. And that is the fact that the epithelium changes as expected, thinner over the steeper area and thicker over the carved out area of a hyperopic ablation. But I'm going to show you how hyperopic LASIK has been made way safer by epithelial mapping than by just looking at keratometry. So here's the post-op the maximum simulating K post-op, and obviously the epithelial thickness is thinner the higher the K, and the donut part is thicker the higher the K, obviously. But look at this example. Here's a patient who has a keratometry of 41 diopters, but the epithelium is already at 26, and we know that the epithelium starts breaking down at about 21 microns. So doing an enhancement of a +1 in this patient is not possible. So it's contraindicated. And yet, from the standard rules, you would say, oh yeah, I can do a +1 in this undercorrection because the cornea is still flat. But you'd be wrong. You'd be creating an apex syndrome in this cornea. Likewise, here's a very steep cornea where it's not 50 yet. So you're saying, oh, look, I can do an enhancement. It's only 49. I can go up to 50. And the answer is no, you can't. The epithelium is already minimum at 26. On the other hand, and this is how our paper was born, here's, a SIM-K, SIM-K of, sorry, I'm just taking my image out of the way here, of 52, with an epithelium of still 36, and I can certainly do a +1 enhancement on this eye, no problem. Likewise here, I can take this 44 diopter cornea and do a +3 enhancement after a +6 and total +9. Of course I can do that because I've got plenty of epithelial space to be steepening this cornea further physiologically in this eye. And we've published several papers on this and apical syndrome and the dynamics and the probability of epithelium not stabilizing. So we published almost 800 eyes with 2 years follow-up, +4 to +7. And we demonstrated the same accuracy and the same, and actually better safety than clear lens exchange, because clear lens exchange has a 2 to 3% loss of 2 lines because of capsular and IOL, issues, optical issues. We get better safety, if you like, with LASIK than we do with clear lens exchange and high hyperopia, but only because we're using epithelial mapping. Super accurate, cylinder control is excellent, cyclotorsion control. And it's all because it's to do with the fact that a flat cornea with thin epithelium can't have an enhancement, and a steep cornea with thick epithelium can have an enhancement. And being able to do epithelial mapping is the key to avoiding 2 intraocular surgeries with less, with a lot more risk, and just doing LASIK on the cornea. And there are many excimer lasers now on the market that do excellent hyperopic ablations for high hyperopia. But let me move on to the more esoteric, but the scariest part and the most important part of epithelial applications, and that is to do with what we called, my ARVO poster in 1994, the law of epithelial compensation. And so if you just memorize this, if there is irregular astigmatism, there is irregular epithelium. That's the law. In other words, if an eye presents with irregular topography, by definition, the epithelium has reached its maximum compensatory function leaving irregularity on the surface, which now is showing as irregular astigmatism. It's very logical. So there can be no such thing as an irregular cornea with regular epithelium. Okay, so another way of doing that graphically is to show that you can have three front surfaces that are identical with three completely different subsurfaces. So the stromal surface can be different even though the topography is the same. And therefore topography or wavefront are inaccurate means of assessing complex corneas. And I know I've developed a reputation for fixing very weird corneas, but it's not out of greater skill than anybody else. I would say it's about having more information than anybody else. And having epithelial mapping throughout my career has been my catapult into therapeutic refractive surgery, and hence why I'm somewhat ahead of the game. I want to show you 4 examples of where the topography just doesn't give you the information. So here's an example of an incomplete nasal flap with a double ablation on the flap, but this is the topography with a truncation. Here's a relatively normal but slightly irregular topography in a patient with multiple procedures. That was actually, no one knew what this was. I was told, it was sent to me as an ectasia, but I diagnosed it as a decentered hyperopic ablation with the centration put here. And this is post-RK 20 years later with 6 lines loss of best spectacle corrected vision. Now, this is all the information you have on the front surface. Let's look at the epithelium underneath those 4 maps. Now look over here, you have a highly irregular epithelium in the region of the short flap. Look here, you've got rings of thick, thin epithelium underneath that surface. Look at this RK, very thin epithelium top and bottom, very thick along this way, tons of cylinder in the epithelium, which you don't see, which you don't see on the topography, right? The topography looks regular, but the surface of the stroma is highly irregular. And here's the decentered hyperopic PRK showing the donut of epithelium with thinner epithelium here. That you can't tell that from the topography. So suddenly the epithelial maps are starting to give you more diagnosis, and then the B scans even more information. So here's the thick, thin, right? In this epithelial map. Here's the short flap with a double ablation with a compensation zone of epithelium that's going to screw up your topography guided treatment big time. Here's your RK. Well, you can see the incisions down here. And here's your decentered hyperopic PRK, where you can see, the Bowman's is missing in the center, in the visual axis. That tells you that there was ablation of the stroma in the visual axis. So PTK, as you all know, takes sheets of epithelium and once it cracks through the epithelium, it starts taking stroma. And, there's now a 6-hour course on therapeutic refractive surgery, which ends with this slide. And the fact is that if you have irregular topography and you have irregular epithelium, you cannot do a topography guided treatment. You have to do a transepithelial PTK, and you can smooth the stromal surface, regularize the epithelium, produce a much better topography, reduce the wavefront errors, and increase the contrast of this eye from very low normal to completely high normal. And that's just with a PTK, and that's because we had the diagnosis. And this case was done in 2006. So just think about how we were thinking way back then, and this is still news because epithelial mapping has not been widely used. There's the intraoperative ablation predicted epithelial removal pattern, and that's what we had at that stage of the ablation. And we can see that we predicted what the epithelium was going to look like exactly by accurate measurements pre-op. And this is the difference in stroma before and after, showing rings of stroma removed. You can't remove rings of stroma with no matter how good your eye tracker is. That is a very difficult ablation to do. And I'm going to finish off with this section with our Louvre gallery of our of our beautiful tableaus of PTK. And this is just PTK. So highly irregular short flaps regularized. Sorry, this is a highly irregular surface here, regularized with one PTK. Here's the other eye of the same eye, highly irregular epithelial thickness pattern, regularized again. And this is what the patient saw before surgery with their best corrected around the light. They drew this. And this is after one PTK, now they're drawing this. So again, not topography guided, not wavefront guided. So the opposite of what a lot of the companies are making you think, that, oh, this fixes all the problems. It's like, no, it fixes all the problems unless the epithelium is irregular. If the epithelium is irregular, you've got to plan your PTK anatomically, and you can fix these things, these what used to be thought of as insurmountable problems. You can fix them very easily with a PTK. And let's be clear, the Vizix 2020B in 1995 was approved for PTK, and that's an old technology. Here's an example of a central island. There was a drop of water on the ablation. It was an inexperienced surgeon. He did all the ablation on his Vizix, and he got this topography post-op. And the patient arrived, and we mapped his epithelium, and with a transepithelial PTK, one go. I mean, we didn't completely get rid of it, but we got rid of it on the surface, and we completely regularized this horrific topography. And now we were able to do another treatment to be able to give the patient the vision that they wanted. That's the difference map of a transepithelial PTK, not a topography guided treatment. And here's another example of a horrendous topography regularized beautifully with this difference map, and the difference map showing exactly the mirror image of the pre-op by looking at the epithelial profile. So, you know, I could go on forever about cornea and epithelium, and I do sometimes. So I'm just going to move now on to phakic IOLs. And my interest in phakic IOLs was very arm's length. Carlo Lovisolo came up to me after a course at the ASCRS in 1999, actually. And that was the year he published this textbook. And I'll point you to this textbook. It's 300 pages long. It's on the ICL, and it was published in 1999. So this guy was, you know, up to here in ICLs already scientifically. And he said, I must get one of these devices. And I said, well, you know, there's a prototype coming out in a few years. We might be able to get you one. He and I worked together for 15 years on sizing of ICLs. I went to visit him after he had his glioblastoma diagnosed, and I was very grateful to Brad Randleman for letting me publish a memorial for him in the journal, because his contributions to phakic IOL surgery were huge. And you know, the things about ICL sizing, everyone knows, are to do with pigment dispersion if the lens is too big, or angle closure, and there are cases of NPL, like total loss of vision in angle closure in aqueous misdirection syndrome. Undersized lenses that can cause cataract, although of course the Aquaport has improved that a lot. But look at this circular cataract here. In the case of a high myopic ICL that was touching in the mid periphery, but not in the center. Okay, so again, looking behind the iris, being able to see there was touch, not in the center. The center showed volt, but not the periphery. People talk about a minimum of 90, but that's because of the mid periphery being hidden behind the iris and causing this circular cataract where there was contact. So yes, the central port has improved things, and that's great. But you know, handheld ultrasound for sulcus measurements has become a standard of care. And if you have an expert user, someone who really knows how to get accurate measurements, you can put this eye cup in, it's to lie the patient down and get sulcus to sulcus measurements. But you know, then there's the sort of the propaganda machine that comes on out the other end. And I'm, with all due respect to Mark Packer, who's a great surgeon and he's done a lot of great work, this was not his best work. This was a very inaccurate paper from a statistical standpoint. It was completely incorrect. I've threw this at a statistician, and he calculated that the conclusions of this paper are exactly the opposite of what they said. They said that there was no difference between ultrasound, and in fact, when he analyzed the data backwards, he found that the best sizing was achieved by ultrasound as opposed to white to white, which is, you can use statistics to tell you anything you want. But this was a paid journal. This, pay $4,000 and they guarantee a publication within 3 weeks, including peer reviewed. So, this is used by a lot of people to justify staying with white to white, but we all know the truth. The truth is that white to white doesn't work all the time. And one of the reasons why there is an objection to ultrasound in sizing of ICLs is because handheld ultrasounds, well, as we know, and this is Carlos' data, the sulcus to sulcus measurement, the repeatability is, about 0.5 millimeter with these handheld devices. And, the in 0.5 millimeter sizes. So yeah, understandably, a UBM is not going to give you this, necessarily better sizing than white to white. But with our Artemis 1, we had 1/4 of a millimeter repeatability. And now with the Insight, we have 1/8 of a millimeter. And so now we're starting to have the accuracy along with the optical versus ultrasound positioning power, right? Because we have the simultaneous image of where the eye is. So now we have the technology to actually tackle the sizing in the most, in the optimum way. And this is side by side just to show you. The ViewMax is a very good high frequency ultrasound device, but it's only high frequency ultrasound. It's not very high frequency ultrasound. And there's a difference between VHF and HF and UHF. So, those are the, that's like a radio, right? There's VHF and so the resolution of the posterior chamber structures is much higher. You can see zonules, with VHF. And, I'm going to go and do some OCT side by sides. And obviously OCT can give you a white to white or an anterior chamber depth, but it can't give you sulcus. And that sulcus, can be wider or deeper. And by the way, the zonular plane of this lens can be anywhere in which you don't know. Whereas with ultrasound, you can have the sulcus. I must get this out of the way here, otherwise I can't see myself. Yeah, you can have the zonular plane. You can have the lens rise from the zonular plane, right? That's where let's say the ICL lies in the zonular plane, and then it has a volt, right? So the volt of the lens can be measured directly from the zonular plane, or you can measure the lens rise from the sulcus plane, but you can therefore determine the actual ICL lens separation and what the effect on the angle will be, which of course is the whole thing. It's the battle with the ICL. So a post-op assessment, I love doing these maps because you get an instantaneous airborne volt measurement, but I don't have the position of the foot plates. And why is that important? Because the foot plates and the lens rise and all of these things are actually correlated. And as we will learn in a minute, these true volt measurements are important. So here's an example of what I can see as a post-op ICL of mine that looks a little tilted. I mean, it's acceptable. No one's going to exchange this ICL, right? I got it. No one's going to exchange it. But let's be clear. There's something not right here because it's not symmetrical. But I can do an ultrasound and I can know why it's not symmetrical. And it's not symmetrical because my foot plate here is riding into the sulcus, into the armpit. It is not sitting as it should do into the zonular plane. And my early experiences with this kind of case are what taught me a better implantation technique. So I implant the ICL, and then I have another step. Instead of just tucking it behind the iris and go home, which is the way you're taught to do this, I tuck it behind the iris and I make sure with my spatula that I've pushed down and made sure that the foot plate is not riding into the sulcus, it's sitting on the zonules, and so I have a consistent positioning. Here's a hyperopic ICL. Again, no information of foot plates. Nice to have if there's a little bit of tilt. You can see again, sulcus versus zonular. Tilt. Again, post-op measurement. This is something that has never come into the vernaculum of the ICL surgeon. We've never talked about post-operative monitoring of the position of ICLs. We've talked about it. If the central volt is fine and the endothelium is stable, that's all you need to know. It's like, well, yeah, but you can do better if you actually check where things are. Orthopedic surgeons don't put in a pin and plate on a hip and go, yeah, it looks pretty good. How is your walking? Good. Okay, fine. You can go. I never have to see you again. They take an X-ray to check the positioning of the pin and plate. So this kind of X-ray verification of what you're doing has been part of surgery for 100 years, except behind the iris in anterior segment surgeons. And we have an opportunity now to enter that. Salvira talked about this a lot. He talks about the fact that the central volt is not what's important. He talks about the fact that it's the mid-peripheral volt that's important in myopic ICLs, because that's where the lens separation is smaller. And if you're measuring it with the dilated pupil with an OCT, you don't know what it is, right? You got to measure it in the physiological pupil state, closed, and therefore you can only make that measurement with ultrasound. And the Saldivar team, Roger and Roberto, have had an insight now for over a year, and they are, all over it like a rash. They're talking about it as, the second coming, because they're, Roberto's put in over 25,000 ICLs, and for someone who's done that to then get excited about something new in that sort of surgery, I think it says a lot. Now, sulcus, by the way, I glossed over this, but we are working on software to do a map of the volt. So the mapping of the volt behind the iris, an incredible idea, okay, for monitoring over time. And this is Ryan Vida's painstaking work, going through every one of our cases and detecting cysts, which of course can lead to foot plate malposition. And hopefully you're detecting it before surgery, right? Of course, the foot plates are not in the horizontal plane in a horizontal implantation. So now we got smart about knowing where to look for the cysts, depending on the rotation of the lens, as prescribed by STAR on their sheet when you receive the toric lens. So there's a little bit more to implanting toric lenses than just looking at the sulcus at the posterior chamber dimensions. Here's an example of the different foot plate positions. This is in a publication which we hope will get published soon. It's been submitted, where we looked at the positioning of the foot plates in all of these eyes that I did, before I was doing this extra technique of ensuring foot plate on the zonular plane. And there's quite a variety of positions, and you can see how even the surgical technique of positioning itself will provide some kind of difference as to how the volt is going to be in these cases. So let's talk about sizing. And essentially here, let's go through it. Historically, we know that white to white is the standard. We know that in Switzerland, Gomvers published the fact that less than 90 microns is a higher risk of cataract formation. And we know that STAR has made the efforts to do multivariate regression analysis of ordinary terms, like the keratometry and the AC depth, which can be derived from any machine, in order to improve the sizing of the ICL. But we also know that the correlations between the white to white and the sulcus are, they're good, they're statistically significant, but they're not sufficient. And how do we know that? Well, here's the study that I did with Tim way back and published years ago, over 10 years ago. And we showed that predicting the sulcus from the white to white, the chances of an error of 0.5 millimeter, which is one size lens difference, is 38%. if we at the time, everyone's saying, oh, you use OCT and use the angle to predict the sulcus. Well, you're still going to have a 32% chance of 0.5 millimeter error in sulcus diameter prediction from angle. Better than white to white, but not great. And in a multivariate regression analysis, with any parameter you can measure that doesn't involve ultrasound, you can get down to 25% predictability using AC diameter and AC depth. There's your AC depth that Starr put in. And so, but it's still a quarter of the cases where you're predicting the sulcus with greater error than 0.5 millimeters. What happens if you use the Artemis 1? Well, it turns out that because, well, actually, we've calibrated. I used to put this down. So with the InSight, 0.12 millimeter standard deviation for that sulcus measurement, the chances of being out by more than half a millimeter is less than 1%. So for sulcus-based sizing, high-frequency ultrasound is far better than white to white or any other multivariate model that Starr might be providing on their website. And we know that many of our colleagues around the world have published papers showing that sulcus to sulcus is better than the Starr website sizing. And, you know, Doherty's paper is the most famous one initially. He did that off the FDA data. And he said that we're going to add the sulcus to sulcus to the equation. And we know that the power of the ICL depends on how much it's going to bend. So with those two parameters, he then tells you which lens to put in. What we found, as Jerry showed a minute ago with Carlo Bisolo and his formula for sulcus sizing, we found that we would have selected a different lens from the Starr website in over half the eyes by using his sulcus method. And this is Carlo Bisolo's formula. In this study, which we published, you see that the interquartile range achieved by sulcus sizing was half the width of that by the Starr predicted size. So already Carlo's work and his formula was way better than using white to white and anything else that was available on the OCOS website. With only one eye with less than 90 microns, as opposed to 26 eyes with the Starr formula. Now, Starr, of course, adjusted their formula to make it up one size a lot of the time, and that's why everyone out there tends to take the Starr website and often take one size down from what they're recommended on the website. But that's a very kind of, you know, thumb in the wind kind of way of doing it. Kojima came along and did a very smart thing and saying, well, look, it's the sulcus to sulcus lens rise determines how close the crystalline lens is going to get to the ICL. So let me add that into the protocol. And so we were using the Kojima formula and cross-referencing it to the Doherty formula, using the InSight, and we were using, you know, all of these parameters. And so we started our ICL surgeries using these methods, and we took our first 42 eyes and did our own multivariate regression model. And now when you're doing multivariate regression models to try and find something new, you've got to stick in everything in the kitchen sink and find out what sticks to the wall. And so we had all of the obvious parameters that to play with, but we also had the parameters that we decided to look at, which were anterior chamber depth, the angle of the anterior chamber, the angle to angle distance, the sulcus to sulcus distance, the sulcus to sulcus lens rise, the zonule to zonule distance, the zonule to zonule lens rise, and something I called the ciliary body inner diameter, which I stuck in at the end. And I said, look, it's probably useless to measure this because the ciliary body, you know, these ciliary body fingers, they kind of float around. So it's kind of like, it's going to be a bit of a crazy thing to put in, but stick it in anyway. Well, it turns out that the ciliary body inner diameter was so statistically significant at predicting the volt of the lens using these other parameters as well. So statistically significant that it threw out the sulcus to sulcus. And I did this work, you know, about 18 months after Carlo passed away. only as a continuation of his work, and only because I wanted to finish the work that we had started together. And I think that if he's watching us from above now, he will be smiling and laughing, because he was very humble, and kind of warm person, and he was completely the opposite of me. He was very nice, and he would just be so pleased that we finally reached the point where we were able to predict things this way. The other thing which I realized we had never done is that, all of the formulas tell you which lens to put in. And based on the Saldívar principle, I was like, well, forget about an equation telling you which lens to put in, because which lens to put in is not just is a clinical decision based on lots of other parameters. So what we said was, let's not tell them which lens to put in, like it should always be 500 microns. How about you give the formula showing for any of the sizes what volt you'll get? And that way the surgeon can decide whether, if in a deep chamber, he might want, in a young patient, he might want to choose the 12.6 to get more volt than in a, let's say, 39-year-old where it's a 2.9 chamber. He's going to probably choose the 12.1 in the same geometrical eye. So now we're moving into customization of volt. So not just reducing the exchange rate, but moving to another phase, which is forget about the exchange rate. That should be zero. Let's talk about customizing the volt. And so our results were as follows. This is the interquartile range of 700 microns or so that we achieved using the Kojima formula. This is what would have happened with the star. And of course, we see that with Doherty and Kojima, it's about the same. So using very high frequency ultrasound gave us almost the same as using high frequency handheld ultrasound with using these sulcus formulas. But we showed that in about a quarter of the eyes, our model would choose a different lens, 2 sizes different from the STAR website. And that's, a quarter of the eyes, 2 sizes different. I'm not talking about whether those eyes would have needed an exchange or not. I'm talking about what would be ideal rather than, dangerous. And so if we analyzed our data using our model before we started doing it prospectively, we found that the model would, at best, could provide a huge improvement in the interquartile range of the post-op volt. And so we did this. But another thing that we looked at in our series was that the lenses that we chose, we noticed that they were not normally distributed. And in fact, see, in a normal distribution, there's a mean, but here there isn't really a mean. Well, there is a mean. It's between 12.6 and 13.2. And so it turns out that the STAR does not provide a lens size that's actually the average eye. It provides one that's slightly larger or a bit more than slightly smaller than the average eye. And what would happen, we modeled this, what would happen if STAR provided a lens in the middle, 12.9? And I'm going to take credit for this. We're the first people to have suggested this. If there was a 12.9, the distribution of lenses we would have chosen would have been a third of the time we would have used a 12.9 and not got slightly higher or slightly lower than we would have wanted to predict. So, this is probably space that we're hoping STAR is looking at and, going into the idea of building a lens that's 12.9. Biotech that has pretty much a copy of the ICL, it's out of patent, so now you can copy it. And Biotech have a lens that's the 13, and they just arbitrarily made a 13.0, not that they'd seen this talk. So their lens actually does have an average size. And I think it leads to the fact that people like Sri Ganesh, who's been putting these in for the last 2 years, and he does a lot of ICLs, has had no exchanges in 2 years, and that's using sulcus to sulcus sizing. But let's show you what happens if we use our formula prospectively. And this was blindly the first set of eyes that we did, the first 34 eyes done with the formula without any adjustments. And we had 90% of the eyes within 300 microns of predicted. Over half the eyes were within 100 microns of predicted volt. Now that's interesting, given that there were these patients, these two patients in both their eyes ended up way out of whack, oversized. They didn't require exchanges, but they ended up oversized. And we looked at those cases, and we looked at some other cases that have been done since of the same kind. And we've now actually got new parameters on our, it's in the new version of our website of iclsizing.com, where these patients, these two patients would not have been oversized because of some jiggling of our parameters that we were managed to do once we got these outliers to come in. So these are the results that we have now. And now you can see that the interquartile range is hugely reduced compared to not just using sulcus to sulcus. And when we look at, so, you know, down to 150 microns, interquartile range, it's incredible. So now it's really like it's prescribing the volt height now. And our iclsizing.com website is, you know, free to use. It's like the ASCRS calculator concept. We have everyone's equation. We have the Nakamura, the Kojima, the Doherty, and you can put in your data, and depending on what you put in is what you get out. It's like the ASCRS website. You can go to it, it's free to use. Here's an example where we just put in the Doherty parameters, just the sulcus to sulcus and the lens power, and you get the Doherty predicted, you know, suggestion. Here's an example where you get the Kojima by putting in also the sulcus to sulcus lens rise and the anterior chamber depth, and it'll give you those. Here's, if you put in all of the numbers, you will get both the Kojima and the London Vision Clinic model. And you know, it's very interesting to see when we look side by side at the Kojima and our London Vision Clinic model. It's interesting to see how off the Kojima can be in some eyes, obviously, because the anterior chamber diameter doesn't always predict the posterior chamber dimensions. I mean, there's no, you know, it's obvious, right? And so Jerry said that he's got this heart anxiety when the patient comes in on post-op day one, and what's that volt going to be? And his heart's beating, and I know that Jerry doesn't want his heart to beat too fast, right, Jerry? So here we go. This is the last few weeks of my heart. I just asked Ryan to pull the charts, and so this is all very small print, so you can't see the numbers, but this is post-op day one, so you know all these volts are going to go down a bit. So post-op day one, we predicted 566, it was 765. 507, it was 510. 555, it was 663. 539, it was 685. 507, it was 348. 417, it was 677. 518, it was 408. 407, it was 467. And that's how it goes in my clinic on post-op day ones of ICLs. I love post-op day one with ICLs because it's like you're betting on a race where you already know the answer and you win every time. It's just great. We know that. Okay, so I'm going to move away from that because that's, you know, that's literally one of the most exciting things I think that's happened to refractive surgery is making the ICL a bulletproof option. But let's be clear that cataract surgery is still in its infancy with respect to knowledge of what is happening behind the dark side of the moon, which is behind the iris. And the ability to measure and get the volume and the shape and of lenses before the surgery is done in the natural physiological state, not dilated, right? Dilated means that the lens can change shape. There's no more tension on the zonules. But this dark side of the moon operation that we call cataract surgery is now going to change. Now, because we can make very accurate measurements of the lens dimensions, things like accommodative lenses that go in the bag Well, different sizes bags will have different mechanical advantages or disadvantages with different size accommodative IOLs. So all of these things that kind of worked but then didn't, all those mysteries as to why this accommodative lens works sometimes but not others, possibly solved by knowing lens dimensions, equatorial diameter, volume, all of these things can now be measured pre-op. And this high resolution lens imaging is now, I would say, the forefront of cataract surgery. Because being able to determine the zonular plane in advance of surgery, in the case of where there's a very large lens, where the AC depth is foreshortened, and the lens is so fat that the centroid of the lens might not be in the right place. And so your Olsen formula is going to possibly be an outlier. And it doesn't matter what regression formula you're using. If you're not able to chart the zonular plane, you may not have the ability to predict IOL power as well. And Zeiss and I are starting a study pretty soon. Dr. Kretz in Germany is getting an insight. I'm hoping to entice Jerry on this, but being able to do pre-op and post-op measurements and then trying to see about zonular plane prediction for IOL power engagement is going to go way ahead of doing intraoperative aberrometry, because all of that takes place outside of the operating room and doesn't involve pressurizing the eye and trying to make it look physiological when you're making your power calculations. Here you've got a pre-op physiological measurement that can then dictate what IOL you're going to put in once you're in the operating room. This ELP is the elephant in the room of cataract surgery. And everyone in the field of IOL calculations, all of the great leaders in IOL calculations know that 25% of the error comes from the lack of predictability of the effective lens position once it's in the eye. And I think we're in the position now where we're going to be able to provide this diagnostic tool so that this next generation of cataract surgeons in 10 years time or 5 years time, when we solve this, is going to be talking about those of us who were using these regression formulas as dinosaurs, because now we get to true IOL power calculations. So the fact is that there are innumerable applications of this technology. I've just shown you some of the ones that only I have been able to do myself with a bunch of help from my team. Can you imagine an army of brilliant people like Jerry, who are now using this technology and able to add to the scientific armamentarium of this? It's going to be a dawn of new anterior segment surgery capabilities. And I thank you very much for your attention in this rather long monologue on the use of high frequency ultrasound in anterior segment surgery. Thank you very much.
Well, the thing is that I think everybody was kind of jealous, to put it very frankly. It's because basically what happens is that white to white will give you surprises, and it sometimes is very frequent, the surprises. So I never had any surprise until my Artemis 2 broke down and I didn't get my Insight 100. So that was like so frustrating. It was like, that was my first and only missized ICL. It's like, oh, I was crying inside. I should have delayed the patient. On hindsight, I should have delayed it until I got the Insight 100 to do it for her. But you think about it and you say, oh, you might as well just do the white to white, and then so that was a disaster. That was a real shame. And the patient was such a nice patient too. I felt really bad. So I will never do ICL implantation without an STS from a high frequency digital ultrasound, very high frequency digital ultrasound, because I think it's just unfair to the patient.
the ICL is a very forgiving technology. So, you know, even with white to white sizing, yeah, it's good 95, 96% of the time, you're not worried. And maybe 2% of the time, you're like, wow, I better watch this thing carefully. And then 1 or 2% of the time, you're like, there's no way I can leave this lens in there. It's dangerous.
Yeah.
And I think when people talk about, well, my exchange rate is only 2% or 1%, I was like, yeah, but exchange means you won't dare leave it in the eye. That's like the limit. Whereas, you know, saying, well, it's a bit high or it's a bit low, but let's see how it goes. That's not a success story, you know, for anybody.
No, I think it's also, you know, your heart, you know, when you do this kind of surgery without the ultrasound, you know, when you see your patient come in the door, your heart is going a bit faster. You don't know whether your chamber is going to be really shallow, or you don't know whether the lens is going to be smack on the lens. You know, it's like, oh, you know, and that gives you all the white hair, you know, and all the stress for nothing. We want stressless surgery, okay? We want stressless surgery, and you know, once we can get stressless surgery, you see the ICL will just take off like a rocket. You know, it's even more stressless than if you can predict all these things more accurately, everyone will do it. Every cataract surgeon has the ability to do ICL surgery. I mean, it's easy. It's just that the fact that you can't size it accurately, that drives me crazy sometimes. Okay.
Well, I think, Jerry, I mean, would you agree that one of the reasons why the ICL isn't more popular than laser, which it easily could have been, because there's more surgeons who know how to do cataract surgery and not cornea than surgeons that do corneal surgery?
Yes, definitely.
So everyone has the skills for cataract surgery. Yeah. Why isn't ICL more popular than laser? And I'd say it's because everyone gets shy of it when they get these, you know, crazy volts and, you know, angle closures. And, and cataracts in young 27-year-old high myopes is the last person you want to do a cataract surgery.
Correct. And the thing is that you can just imagine, you know, you don't even have to worry about posterior capsule. You just imagine, you know, when you do a cataract surgery, you're always worried about breaking the posterior capsule. The posterior capsule is not even there. I mean, you know, all you need to do is be careful. You don't poke the anterior chamber, the anterior surface of the lens. That's it, you know. And that's easy. Most of us, when we do cataract surgery, we stab the eye. We never touch the lens, you know. So this is something that is in the wheelhouse of every cataract surgeon. In fact, I would give up cataract surgery and still continue doing ICL, because I think ICL is easier than doing cataract surgery.
But just the short answer is that if you go to my JRS paper on epithelial thickness profiles, you will find that although the average profile looks like the top will break through first and then the bottom, which means that you're inducing coma when you're doing a transepithelial PTK, that's the average profile. So here you are. Here is a cylindrical epithelial profile in a normal eye, a virgin eye. So if you do a transepithelial PRK, you're going to induce cylinder onto the stromal surface. This eye, you can see that the epithelium is thinner in the center and thicker in the periphery. So you're going to break through in the center first and later in the periphery. So you're going to induce a hyperopic shift from the epithelial profile. And the fact is that if someone were to do a properly controlled trial, not the one that's already published, which just shows that the means are the same, but an outlier analysis of trans-PRK versus advanced surface ablation removing the epithelium with alcohol, you'd find that you're going to have less outliers if you do alcohol removal than if you do trans-PRK. That's a fact. Now, it's only a few eyes because, as you can see, most of the time, the profiles are just coma. So most of the time, you're just going to introduce coma onto the stromal surface. which also isn't great, but most patients don't notice a little bit of coma. I mean, that's how the oculentis works, right? The plus 150 has a little bit of coma in the eye, and most people get used to it. So trans-PRK, in my view, is not a great procedure compared to regular PRK, although it does have certain advantages, which I agree on, that does heals faster, whatever. But trans-PRK isn't going to be really good until we're measuring the actual epithelial profile and ablating it directly with the excimer laser. So I hope that answers your question.
Well, the thing is that when you say there is definite keratoconus, what is he actually using as the diagnosis of definite keratoconus? Because we all know that the corneal epithelium always compensates for the cone. So if you see an abnormal topography and it looks like a cone, but the epithelium is normal, then I would say that something's wrong here. It's probably one of those people who have basically an abnormal cornea, but it's not keratoconic. If that's understood. In other words, keratoconus always shows epithelial changes first. You know what I mean? And that's it. And the thing is that if you have a cone that looks like a cone, it could be something else. It could be some other thing going on with this cornea. What do you think, Dan?
You'll see that there are cases where you can get a false keratoconus diagnosis from epithelium also. How does that happen? Well, it happens in dry eye, and it happens in ABMD. It happens in what we call subclinical ABMD. There is no map dot fingerprint. There's nothing on the cornea, but the epithelial profile is irregular, and that's because of reduplication errors, which you can't see at the slit lamp. It doesn't cause irregularities that will have negative staining. And your epithelial map enables you to diagnose ABMD in those cases. So I show in this talk cases where you can have epithelial profiles that are classified by the RSK as keratoconic, but they're not. So remember, I showed you that the sensitivity and specificity is better than any tomographer or topographer in the world, but it's not 100%. You still have to use your clinical judgment. So you can have cases where you have epithelial profile that looks like it's keratoconus, it's donut shape, but then you have to correlate that with the fact that the back surface is completely normal, and therefore it can't be keratoconus. That donut shape in the epithelium has to be for a different reason. If the epithelium does not have focal thinning, where the back surface has made the machine tell you it's definitely keratoconus, I think it isn't keratoconus, guys. Because keratoconus involves thinning and steepening, and the front and back surfaces are yoked.
Yeah.
If they're yoked and you have an anterior surface extrusion, by definition, you'll have an epithelial thickness profile focal thinning over that extrusion. So I showed you that wild case with the keratometry of 55 with the high myope. It was a corneal myope, if you like. It was the axial length wasn't that long, but he had a very steep cornea. So it was a corneal myope. So yes, I think you're right. And now having said that, you've got to use your clinical judgment. Nothing is going to give you nothing is going to give you a guaranteed answer using one test. And I like the way Renato Ambrosio is talking about keratoconus screening now. He talks about the fact that we need to be multimodal in the way that we're talking about diagnosing keratoconus. We need to look at the topography. We need to look at the tomography, the back surface. We need to look at the epithelial profile. We need to also look at possibly at the mechanics of the cornea with the corvis. Maybe that's just one other piece of information. And we have to be multimodal about this in terms of being certain. And of course, even if we're certain, it's biology, so we're always going to be wrong sometimes. But I think that if you're not using epithelium, you are at a big, big disadvantage in 2020. It's just, you're way behind. The number of cases that I have done LASIK on with a Hansatome after proving that the abnormal topography was not keratoconic is published in the JRS. So there's a paper out there which you'll see. We've taken abnormal topographies proven not to be keratoconic by epithelium, done Hansatome LASIK on them with, you know, major flaps, and compared them to match controls over time and show that the cylindrical control was exactly the same. It was 92 eyes. We don't have a single case of ectasia there. And like I say, we've done 7% more LASIK year on year just because we had epithelial measurements. So calculate that in terms of income. Ten patients at $6,000 that you wouldn't have otherwise done, you've now paid for your device. And that's like the cold statistics. Let's think about it the real way around, the way that got us into like applying to medical school. Do no harm, you know, prevent ectasia, give patients, and don't deny someone LASIK when they could have had LASIK. You know, the epithelial map puts them in the OR rather than keeping them outside with a cross-linking and an ICL, which is, yeah, it's an option, but it's a hell of a lot more work than a 3-minute procedure that heals in 3 hours called LASIK. So we have, you know, I know there's people out there saying that ICL should be the only procedure. It's like, no, of course not. It is not reasonable to offer an intraocular surgery to a patient who's perfectly acceptably can have an extraocular procedure. I mean, that's economically, that might not be the way the market goes because there are more cataract surgeons than LASIK surgeons. But I mean, if patients knew as much as we did, they wouldn't choose an intraocular surgery versus an extraocular surgery if they had the choice and the knowledge to know about this difference. And the epithelial map is going to take you there 95% of the time. You've got to be a clinician still. I mean, I get inundated, unfortunately, with can I do this case or not emails from ArcScan users. Look, I'm not complaining because I'm delighted that people are using the damn thing. But the fact is, you know, you don't need confirmation from me every time. If it doesn't look right, then don't do the surgery. I mean, you can't be right 100% of the time. And I'm not smarter than anybody else. I'm looking at the same data and I'm saying, well, this focal thinning, it's right where the back surface is. Even though the machine tells you it's not keratoconus, I would say don't do a corneal procedure. If it's a -1, yeah, do PRK. But if it's a -5, I'd say no, don't whack out all that tissue out of a cornea that already has those features. Even if you're legally sound in court because the tomographer says it's normal. The fact is, I believe over the next few years, it's going to become legally unsound in the case of ectasia to not have used an epithelial map. I mean, 2015, we're now 5 years from the first approval of epithelial maps by ultrasound and by OCT. So you're 5 years in and you're not using epithelium. I don't think that's going to be a good position to be in. I mean, I don't know. What would you say, Jerry? You've been around epithelial maps for a long time as well.
Yeah, I think it's definitely added another dimension to our security as well as our knowledge on whether to do a case or not to do a case. Because when you look at normal epithelial maps, you can basically say, okay, this guy looks pretty safe to do. And if it's abnormal, then you look whether it's a pathology of the epithelium, like what you were saying. And if it's a stromal problem, then it's going to show up in the stroma and not in the epithelium. So at the end of the day, every little bit of information helps us. I think that's the most important thing of everything. Yeah. And you and I are crazy. I mean, I got tons of OCTs and tons of everything going on. And people always ask me why I buy so many machines, because I tell them this machine is good for this. This machine is good for epithelium. This machine is good for sulcus to sulcus. And at the end of the day, I think people think we're crazy, but I think obsessive compulsive perfectionists are always drive the knowledge. I think that's what you are doing. And
Well, that's what I mean.
I'm a follower. I'm a follower.
No, no, come on. Jerry was the head of SNIC. He made it into what it is today. He's given the mantle onto Donald Tan. He's created a huge generation of world-class ophthalmology clinical and research tools. You went into private practice. I understand that because I did the same thing. It gives you masses of freedom to operate in the way you want to without committee decisions about what machine to buy. So I went into private practice for the freedom. I've published more in private practice than I ever could have published if I stayed at a university with everyone, all over the place telling me what to do and what I can't do. But, I think what you're talking about, this obsessionality, has been simplified. And I would say that, it used to be that you had to have an atlas for the front surface, an ArcScan for the back surface with a technician who knows how to do it better, because the back surface on the ArcScan was still better than the Pentacam, just harder to get. And you needed an Artemis 1, this big Volkswagen looking thing, for the epithelium. And it was like, oh my God. Now, here's your deal, guys. Here's your shopping list here's your Christmas. Here's your letter to Santa. Okay, you got another few days to go before Santa comes around down your chimney. And dear Santa, all I want for Christmas, I should put a little guitar on this. All I want for Christmas is an ArcScan Insight 100 with all the bells and whistles and an MS-39 from CSO. That's all I want for Christmas. And I'm going to sell all of the equipment that I have here on eBay to whoever wants to buy it. Because with those two devices, I have the highest standard of care that I can offer to my patients. And I'm going to reduce my own anxieties and my own pitfalls and cul-de-sacs that I get into with not having the diagnostics in advance. I've got my OCT for the cornea. I've got my anterior segment OCT. I've got my airborne instantaneous measurements. I've got my 80% epitheliums that I can just go straight through to surgery. But I also have my ultrasound, terminator of the decision for epithelium. And I've got my ICL sizing thing. We know that STAR is extremely successful in China for obvious reasons. It's a highly myopic population. What do you think about the near future of this tsunami of ICLs that have gone into Chinese eyes? Is there, my experience with Chinese eyes is that, they don't have the same relationships, anterior chamber depths and myopia as Occidental eyes, like European eyes. What do you think about the lack of posterior chamber sizing in these millions of ICLs that have been going in over the last few years, and maybe over the next few years before China catches up on the use of posterior chamber sizing? What can you comment on that?
Oh, that's a difficult comment, because basically at the end of the day, I deal with a lot of Chinese patients, and I don't deal with a lot of European patients with regards to ICL implantation. Now, what happens is that we find that at the end of the day, it's, how do you say, it's difficult to get information from these millions of cases coming out from China. That's the problem. And the Chinese ophthalmologist is a little bit different from European. You guys like to share your knowledge, and you like to, but a lot of problems can occur and nobody says anything. So we hope that one day somebody in China will start using the Artemis and really start finding out whether all these millions of lenses, how many real problems there are in it. And at the end of the day, I think it's nothing to lose. I think once the Chinese catch on to anything, and they find it useful, it just explodes. It's just a matter of introducing the technology to them. No,
Yeah.
that's my take on it. But for accuracy wise, I already told you my own personal experience. I love the machine. I mean, it has to be the best way to do ICL surgery. But nobody should do ICL surgery without proper measurement of sulcus to sulcus. And that's about it.
Well, if we, and you know what, if it wasn't this time of the morning or night or wherever everybody is, we had Roberto Saldivar here, you know, who's put in more than 25,000 ICLs. You know, we would have him go on about this as well. I've seen him on many. There are, if you look him up on YouTube, there are some the King Khalid lecture series in this from the Saudis. There's a whole ICL sizing session there that lasted, I think, 3 hours. Where Saldivar was going on and on and on about how, you know, critical this new technology is for, you know, bringing ICLs to the safety that they deserve. Because, you know, let's be clear, the ICL is an incredible product. I mean, if that thing is in the right size, you can leave it in the eye. We know that. There's 20 years. You've been putting them in since 2006. I chickened out. I only started after Carlo died, and I had to put them in to finish the work. He was like, well, he's not here. I got to do this myself now. But I was chicken because of the sizing issues. I mean, there was one eye in the UK that went blind because of angle closure. You know, it had aqueous misdirection syndrome. And, you know, there's nothing, it's incredibly, I would let that guy do my cataract surgery. He's one of the best cataract surgeons in the UK. But it was not his fault. It was unable to prevent that angle closure, which led to aqueous misdirection. When they were apparently they were in the OR at 2 a.m. trying to lower the pressure. It was too late. The eye went NLP. And you know, I don't care whether it's inconvenient. I mean, there's a lot of commercial arguments against doing ultrasound scans. And I don't know. I don't think there's an ophthalmologist who would dare have this debate that we're having now in front of patients and say, well, you know, it's kind of inconvenient. The water bath, sometimes you get a little bit of water on the shirt. You know, it's I don't know. It's not really good for my practice, that kind of thing. It doesn't fit in the workflow into my practice. How many times have I heard that in the last 20 years? If I had a pound for every, you know, a dollar for every time I've heard that. But that's not what patients come to us as doctors for, you know. And I don't want to sound righteous here, but I'm, you know, it is ArcScan that has put us in a position finally where the sort of workflow and all those arguments about convenience are now optimized as much as they can be. And I had never seen this video that you just showed, but tears were coming down my eyes when I saw your optometrist taking a couple of minutes to take a woman, you know, who's like, you know, short and wide, and putting her into this ArcScan. And then within a couple of minutes, you have your anterior segment scan for your ICL size. I mean, how that cannot be considered to be an essential gateway into the insertion of a foreign material into the posterior chamber that you want to stay in forever, I do not know. Yep. You know, and you know, we're obviously preaching to the converted here. No, I have no experience with the CASIA-2 and epithelial measurements. I could do, actually, because Topcon has, my retina colleague has the latest Topcon technology in his department downstairs. But look, I would say that, yes, it must be the same, because OCT cannot resolve the tear film from the epithelium, not current OCT. There are experimental OCTs, but the laser sources are treble the price. And so it makes these, you know, to have that kind of resolution to take the tear film out costs 3 times as more. You're talking 150 to 200,000 to buy an OCT commercially of that kind. So currently, I would say, even without trying it, I hope I'm not sticking my neck out here, but I think that the Cassia cannot do any better than the MS39 from CSO, or than the Avanti from OptoView, or from the Cirrus 5000 with the anterior segment lens from
Zeiss.
From Zeiss, yeah, exactly, from Zeiss.